Bismillahirrahmanirrahim. In this video, variant form of rheumatoid arthritis and juvenile idiopathic arthritis are discussed with these references. So the classical clinical scenario for sacroiliac arthritis is a 22-year-old man present to your office complaining of low back pain and stiffness. Upon further questioning, you discover that he occasionally has sharp pain and burning in his eyes. He denies any recent GI symptoms or illness, and he is not sexually active. Various variants of rheumatoid arthritis are noted, or one of these is Felty syndrome, in which there is polyarticular rheumatoid arthritis with splenomegaly, hypersplenism, and consequent hematological derangements. Then there is juvenile idiopathic arthritis and seronegative spondyloarthropathies. The juvenile idiopathic arthritis, also termed as Still's disease, about 30,000 to 50,000 cases have been reported in US. It is a heterogeneous group of disorders of unknown etiology that presents with arthritis before the age of 16 years and persists for at least 6 weeks. So the Still disease, or JIA, juvenile idiopathic arthritis, is a disease of large joint of female, lead to functional disability, and rheumatoid nodule and factor are absent. There are some differentiating features of this juvenile idiopathic arthritis from rheumatoid arthritis. These are that it is oligoarthritic, means few joints are commonly affected. Then systemic disease involvement, it is more frequent. Large joint are affected often more than the small joints, and rheumatoid are a factor and nodule are absent, while antinuclear antibody seropositivity is common. However, it resembles with the rheumatoid arthritis in some other ways. It is associated with HLA types, certain HLA types, and PTP and 22 gene variants, and the inflammatory cells which are involved in this in the rheumatoid arthritis, such as Th1 and Th17, and inflammatory mediators such as interleukin 17, gamma interferon, and TNF are also involved in the process. Based on the clinical and laboratory findings, the juvenile idiopathic arthritis is subclassified into systemic arthritis, oligoarthritis, RF positive and RF negative arthritis, enthesitis associated arthritis. Enthesis is the area in the bone where ligament or cartilage is inserted. So if there is inflammation of that area, that is enthesitis associated arthritis. Then psoriatic arthritis and undifferentiated arthritis that cannot be fitted to any of these categories. The risk is associated with genetic susceptibility and other environmental factors, as we have seen that the disease is heterogeneous, and this indicates that many factors play their role in the causation of the disease. Morphological features are similar to the rheumatoid arthritis, and there is significant evidence of the abnormal immunoregulation and prevalence of activated CD4 memory T cells in the joint, and cytokine production is prominent, and cytokine production is the basic phenomenon which regulate this process, or which drive the process rather. So the treatment for this juvenile arthritis is similar for the rheumatoid arthritis are use of systemic interleukin 6 antibodies are also being implicated in this disease. Prognosis is very variable, and however 10% of the people they develop disability. The polyarticular disease with systemic symptoms affect 20% of the cases of the GIA. This disease is abrupt in onset and associated with spikes of high-grade fever, migratory skin rash, that is transient, lymphatic adenopathy, and hepatosplenomegaly, serositis, both pleural or pericarditis, anemia, and leukocytosis. The pupil may experience recurrent flares of persistent uh, disease, and it results in significant morbidity. Long-term prognosis of juvenile idiopathic arthritis uh, is very variable. So 10% of these cases they develop serious functional disability, and 25% they develop severe disease. The most common category of juvenile idiopathic arthritis or GI is oligoarthritis variant, which is also termed as uh, polyarticular variant, and it affects more than 50% of the people that are affected by the juvenile idiopathic arthritis, and it affects 4 or less than 4 joints during first 6 months of the disease in the absence of psoriasis or an HLA-B27 type of genotype. This arthritis is asymmetric and develops at an early age. The mean age is less than 6 years. The arthritis is commonly associated with iridocyclitis, which is inflammation of iris and ciliary body, and frequently it is positive with antinuclear antibody. The rheumatoid factor associated polyarthritis or seropositive polyarthritis affect less than 10% of the individual, and it is similar to the adult form of the rheumatoid arthritis, but it is seen mainly in the teenage girl. HLA-D4 is also present in this. Rheumatoid factor negative polyarthritis also affect less than 10% of the people. It affects more than 5 joints within the first 6 months, and it consists of several subtypes that have features that overlap with oligoarthritis and rheumatoid factor negative arthritis in adult, and is a subset that shows stiffness and contraction but little swelling. More than 50% of these people who develop rheumatoid factor negative polyarthritis, they develop serious severe type of the arthritis. The enthesitis associated arthritis commonly affect male children, and the age of onset is less than 6 years. The HLA-B27 association or positivity is common, and it affects mainly at the site of insertion of the ligament on the joint. Then there is final category undifferentiated arthritis. The people who are not fulfilling any inclusion criteria in other group and they have got overlapping feature, then they are labeled as undifferentiated arthritis. There is another term that is seronegative spondyloarthropathies. These are the group of disease that develop in genetically predisposed host and are initiated by ubiquitous environmental factor, especially the infectious agent. The characteristic of these arthropathy are the absence of rheumatoid factor, hence these are termed as seronegative. The pathological changes are mainly in the ligament attachment rather than the synovium. Sacroiliac joint is most commonly affected. There is association with HLA-B27. Bony proliferation lead to ankylosis, and these arthropathies are frequently associated with extra-articular manifestations such as skin involvement, eye involvement, central nervous system, and cardiovascular system involvement. The entities which are included in the seronegative spondyloarthropathies are ankylosing spondylitis, reactive arthritis, psoriatic arthritis, and arthritis associated with inflammatory bowel disease. So the ankylosing spondylitis, that is a subvariety of seronegative spondyloarthropathy. It is one of the, this is also termed as rheumatoid spondylitis or Mary-Strumple disease. It is a chronic synovitis that causes destruction of articular cartilage, and it results in bony ankylosis, especially of the sacroiliac and apophyseal joints between tuberosities and processes. If there is inflammation of tendon and ligament, tendinoligament insertion, it results in the ossification and produce squaring and fusion of the vertebral bodies and bony outgrowths, which together result in severe spinal immobility. The onset of disease is between the age of 20 to 30 years, and this is about twice common in men than in women, and the patient represent as asymmetric low back pain and spinal immobility. The frequently affected joints are sacroiliac, hip, knee, and shoulder joints, which are affected in about 1/3 of the cases. The pathogenesis of the disease is linked with HLA-B27, which is present in more than 90% of the cases. The HLA-B27 role, it is not clear, though it is linked with the antigen processing and presentation to trigger the disease. Recently, ARTS gene, ARTS1 gene, that encode a peptide that trims antigen being processed for presentation by class 1 HLA molecule involvement, and interleukin 23 receptor gene for interleukin 23 receptor that encodes interleukin 23. It promotes Th17 responses. So complication of this disease are fracture of the spine, uveitis, inflammation of the aorta, and amyloidosis. So ankylosis of spondylitis symmetrically affects sacroiliac joints and then involves smaller joints of the posterior element of the spine. Due to resultant destruction, a spine fuses posteriorly, then vertebral bodies become square as shown in this picture. The vertebral column, which is cut vertically to show the square shaped vertebral bodies and fusion of the bone bridges. Later, in the intervertebral disc, they also ossify. The discs also ossify, and intervertebral disc disappear and can be replaced by bone marrow. There is osteoporosis of the vertebral bodies also due to disuse atrophy. Ankylosing spondylitis is a crippling disease, but there is no effect on the lifespan. Sacroiliitis is the common feature of ankylosing spondylitis. Here you can see that in this radiograph, the sacroiliac joints are inflamed and narrowed, and they are more wide due to bony sclerosis that is present around the joint. The patient may present with fever and reduced range of motion. This illustration is demonstrating the pathogenesis and progression of ankylosing spondylitis affecting the spine. The figure is divided into 4 panels A to D, and it is showing the transition from a normal spine that is displayed in A to inflammatory changes, and finally to the spinal fusion, that is ankylosis, that is seen in D. So here the normal spine figure, the A, it is showing the normal anatomical structure of the vertebral column. There are vertebrae that are separated by intervertebral discs. These intervertebral discs are shock absorber and maintain flexibility and spacing between the vertebrae. The spinal column maintains its normal curvature and mobility. Then in B, there is a normal spines with ligamentous attachment. Here you can see the ligaments are attached to stabilize the spine. These ligaments uh, maintain alignment and controlled movement of the vertebrae. In inflammation, that is here in C, here you can see that it is showing the early inflammatory phase of ankylosing spondylitis. There is inflammation of the ligament and inflammation of ligament insertion site, that is enthesis, and it is called enthesitis. Inflammation occur where the disc contacts the vertebral body. Inflammation of the spinal joint is also seen. So consequences of all these inflammation is back pain and stiffness. There is reduced spinal mobility and destruction or early destruction of the structures. Then the final stage is fusion or ankylosis. Here advanced stage of ankylosis are seen. So the chronic inflammation, it leads to ossification of the ligament, fusion of the vertebrae, fusion of the spinal joints, and this produces a rigid spine that is sometimes called bamboo spine. And clinical effect of these changes are severe loss of spinal mobility, fixed posture deformity, increased risk of spinal fractures. So the fundamental lesion in ankylosing spondylitis is enthesitis, leading to a new bone formation and syndesmophyte formation, ultimately causing vertebral ankylosis. Microscopically, the ankylosing spondylitis is characterized by chronic synovitis and fibrosis. There is destruction of the articular cartilage, and also all these result in bony ankylosis as seen in this X-ray. There is tendinoligamentous ossification and some bone spurs are also formed. This is an X-ray from a patient suffering from ankylosing spondylitis, and here this pelvic X-ray has sacroiliitis. On the left side there is narrowing and sclerosis of the sacroiliac joint, while on the left side, while on the right side it is relatively normal. Another member of this seronegative spondyloarthropathy is reactive arthritis, which was previously termed as Ritter's syndrome. This is the triad of arthritis known as gonococcal urethritis or cervicitis and conjunctivitis. Following an infection, the arthritis in this entity can be mono or oligo arthritis, or it occurred day to week following genitourinary or gastrointestinal infection. HIV is also associated with this reactive arthritis. Then the pathogenetic mechanism uh, for this entity is autoimmune reaction, because 80% cases are positive for HLA-B27. Prevalence of this disease is 30 per 100,000 adults, many in their 20s and 30s with arthritic symptoms following urethritis or diarrhea, and this arthritis involved ankle, knee and feet. Asymmetrically, with the low back pain and joint stiffness, repetitive episode for about 6 months, and 50% of the patient have recurrent arthritis, tendinitis and lumbosacral pain. If the disease persists for more than 6 months, this is termed as chronic reactive arthritis. Spondyloarthritis and spinal involvement are indistinguishable from ankylosing spondylitis. It is associated frequently with enthesitis, in which infrequent sites such as Achilles tendon and calcular plantar fascia, which result in heel swelling. Dactylitis, that means sausage-like digits. It is infrequent, but it is also seen. Low back pain is also seen. Joint stiffness, digital tendon sheath involvement, synovitis will result in sausage finger or toes. Spur formation is also seen in calcaneum or some tendinoligamentous sites insertion. Extra-articular involvement is conjunctivitis, uveitis, dysuria, pelvic pain, urethritis, balanitis, cervicitis, mucosal ulcers, cardiac valvular disease, and aortic insufficiency. And there are some cutaneous manifestation also, such as skin rashes, psoriasis-like name changes. Enteritis-associated arthritis is one of the seronegative spondyloarthropathy, and these present with abrupt onset of arthritis of knee, ankle, wrist, finger and toe, and it lasts for about 1 year and then generally subsides, and it is rarely accompanied by ankylosing spondylitis. 7% of the people with psoriasis, they develop psoriatic arthropathy or psoriatic arthritis, and the disease is mostly it is asymptomatic but can be painful, and initially the interphalangeal joints of the hand and feet are affected, and later on more joints are added, that are ankle, knee, hip, spine and wrist. Microscopic features are almost same as that for rheumatoid arthritis. Arthritis is also associated with inflammatory bowel disease, that are Crohn's disease and ulcerative colitis, and affect 20% of the cases of inflammatory bowel disease. There is association of HLA B27 and 14 from the enteric bacteria. They are structurally related in a manner that affect antigenic presentation to the C cell receptor, hence are responsible for the progression of the arthritis. Severity of the arthritic symptoms, they depends on the extent of the bowel disease, and beside the joints, other areas of the body which are affected by the skin by the inflammatory bowel disease are ankle, knee, bowel, liver, digestive tract, skin, eye, spine and hips. So this 22-year-old man who presented to your office with low back pain and stiffness, upon further questioning you identified that he has sharp and pain and burning in his eyes, and he denies any GI symptom and illness, and he is not sexually active. On physical examination, there is pain and limited range of motion of the lower back, and X-ray of the spine shows that there is a sacroiliac joint disease. Thank you for your attention. If you have any query, please write in the comment box.